Hello everyone, welcome to my YouTube channel. This is Sir Steven, and for today's session, we will talk about the hematopoietic and immune systems as the second part of our medical histology laboratory. And further, we'll discuss the processes of your bone marrow, the thymus, and moving forward with our remaining topics and remaining histological slides in this histology laboratory. So your bone marrow is undergoing hematopoiesis. Hematopoiesis is a cell production in your bone marrow that is highly regulated, that are both inducers and suppressors in its microenvironment. We have also the hematopoietic and the mesenchymal stem cells that are delineated by functional properties or a specific immunophenotype. Cell types that are produced by your hematopoietic stem cells include erythrocytes, the neutrophils, the eosinophils, and the basophils, the monocytes, the macrophages, the dendritic cells, the mast cells, lymphocytes, natural killer cells, the osteoclasts, and the platelets. The microenvironment specifies each lineage production at site at submicroscopic level. The mesenchymal stem cells produce fat cells, osteoblasts, vessels, and stromal cells. The blast is the term used for earliest identifiable cell in each hematopoietic lineage. Unique features of your hematopoiesis is including endomitosis of the megakaryocytic lineage cells and your enucleation of your red blood cells. When it comes to the macroscopic anatomy, specimens that can be assessed including the bone marrow core biopsies, imprint preparation, the clot sections, the bone marrow aspirate smears. We have also anticoagulated aspirate samples that can be used for numerous specialist studies, including the flow cytometry, cytogenetics, and molecular assays. Let's start with the first diagram. This is a schematic illustration, likely the hematopoietic in a curved white arrow and the mesenchymal in bold white arrow stem cells which reside in distinct niches. Osteoblast in a black single arrow and the macrophage in a single blue arrow play key roles in your hematopoietic regulation. On your right, the graph displaying an age-related variations in the production or proportion of erythroid, granulocytic, and lymphoid lineages within your bone marrow. Note that the age-related variation of erythroid and lymphoid lineage cells, while the granulocytic lineage cell levels are fairly stable throughout the life. On your left is a bone marrow aspirate smear at an intermediate magnification showing you an admixture of a developing myeloid and erythroid cells. Note that the immature myeloid cells are least numerous in single black arrow and the maturing forms predominate with intact nuclear and cytoplasmic maturation. Erythroid cells in bold black arrow are generally less numerous than the granulocytic cells. On your right is the morphologic features of the nuclei and the cytoplasm of a developing hematopoietic cells that are best appreciated at high magnification. On your left, on clot sections, the overall cellularity can be assessed, 70% in this image. In addition, hematopoietic cells including erythroid colonies are also evident in your blue single arrow. Note also that hemosiderin in the individually dispersed macrophage in your bold black arrow. On your right, on bone marrow core biopsies, bony trabeculae are evaluated in addition to hematopoietic and stromal cells. Bony trabeculae in normal adult patients do not show evidence of remodeling. Note dispersed megakaryocytes in a single black arrow and erythroid colonies in bold blue arrow. On your left, this bone marrow clot section shows an individual megakaryocyte in your blue single arrow and multiple foamy macrophages in your bold black arrow. Macrophages are typically inconspicuous on clot and core biopsy sections. On your right, macrophages can be assessed on bone marrow aspirate smears and should be evaluated for nuclear features and the cytoplasmic contents. Note the ingested nucleus likely from an erythroid cell in bold black arrow and the adjacent hematopoietic cells are unremarkable. On your left is the granulocytic lineage cells. This is a bone marrow aspirate smear showing you numerous maturing granulocytic lineage, including your promyelocytes in single black arrow, the myelocytes in bold black arrow, the metamyelocytes in curved black arrow, the band neutrophils in blue single arrow, and a mature segmented neutrophil in a bold white arrow. On your right, an immature granulocytic cell such as this central promyelocyte in bold black arrow that have a basophilic cytoplasm and sparse granules, while the myelocytes in curved black arrow and successive granulocytic lineage cells that have eosinophilic cytoplasm due to secondary granules. On your left is a nuclear indentation that distinguishes from a metamyelocyte in a bold black arrow from a myelocyte in a curved black arrow, although maturation is a biologic continuum. Note that the darker primary granules are more conspicuous in the myelocyte. On your right, the band neutrophils in bold black arrow are distinguished from a segmented neutrophils in a curved black arrow by nuclear features. Band neutrophils have uniform C-shaped nuclei without constriction. Terminal maturation is characterized by progressive nuclear lobulation, just beginning in the neutrophil that is shown here in this right image. On your left, the normal paratrabecular localization of the immature granulocytic lineage cells is in bold arrow, which is evident in this high magnification image of a bone marrow core biopsy. More mature granulocytic lineage cells in curved black arrow are localized in the central regions of the core biopsy and are thus readily available for release into circulation. The lower edge of this biopsy shows the paratrabecular localization of your normal immature granulocytic lineage cells that are highlighted by your myeloperoxidase staining in a curved bold black arrow. This is your erythroblasts. Erythroblasts in the center are characterized by a high nuclear cytoplasmic ratio and a deeply basophilic cytoplasm. Dramatic nuclear and cytoplasmic changes characterized maturation. On your right, a more mature erythroid lineage cells show gray to eosinophilic cytoplasm, reflecting of hemoglobin production. There is dramatic nuclear shrinkage and pycnosis in a bold black arrow with ultimate extrusion of the pycnotic nucleus in a curved black arrow. Erythroid cells tend to aggregate in colonies here. On your left is an erythroid cell selectively attached to a macrophage producing a so-called nurse cell. This adherence is critical for iron hemostasis. The macrophage is also immediately available to ingest extruded pycnotic erythroid cell nuclei in a bold black arrow in the terminal stages of erythrocyte maturation. On your right, this is the macrophage seen on an aspirate smear. It contains abundant storage of iron as seen in this iron stain. On your left is an immature megakaryocyte with a non-lobate nucleus that is evident in a bold white arrow compared to a hyperlobated mature megakaryocyte in a single white arrow. Megakaryocyte maturation is characterized by progressive doubling of DNA without the cell division or called the endomitosis. On your right, this mature megakaryocyte has a voluminous amounts of cytoplasm which will eventually shed off directly in the circulation as platelets. Neutrophils may pass through megakaryocyte cytoplasm in bold black arrows. We have your fat cells. Adipose or fat cells are a normal constituent of the bone marrow microenvironment. On your left, these cells can have multiple vesicles, especially during regeneration following bone marrow suppression. On your right, the mast cells are an inconspicuous cell in bone marrow aspirate markers or smears, especially within the darkest staining regions of the marrow particles. The dark purple granules of the mast cells obscure the round nucleus. On your left, the plasma cells in curved black arrow are evident on bone marrow aspirate smears and can be identified by their eccentric nuclei and basophilic cytoplasm. A pale paranuclear Hoff region is evident in blue single arrow. Plasma cells can be or may be confused with erythroid precursor cells in bold black arrow because both cell types have a deeply basophilic cytoplasm. On your right, the plasma cells are present in a perivascular location on bone marrow core biopsy sections. On your left is an immunohistochemical staining for CD138 that can highlight the number of distribution and location of plasma cells in bone marrow core biopsy sections. Note that the CD138 plus plasma cells form a collar around small blood vessels. On your right, The binucleated plasma cells in a bold black arrow may be seen on bone marrow aspirate smears. The binucleation is not indicative of a neoplastic plasma cell disorder and can be seen in many reactive processes. Next is your osteoblasts. On your left, the osteoblasts are bone-forming cells that can be seen on bone marrow aspirate smears, especially in pediatric patients. They can be numerous in children with physiologic active bone growth and remodeling. Osteoblasts have a markedly eccentric nuclei that appear to be separating from the cytoplasm in a bold black arrow. On your right, on high magnification, an osteoblast is characterized by an eccentric nucleus and a HOF cytoplasmic pale area, which unlike the plasma cell is separated from the nucleus in bold black arrow. On your left, osteoclasts can also be seen on bone marrow aspirate specimens in pediatric patients. These cells are characterized by multiple separate nuclei rather than their interconnected lobulation of your megakaryocytes. Osteoclasts are derived from hematopoietic stem cells and function in bone marrow resorption. On your right, the more mature osteoclasts may contain a coarse cytoplasmic bone sand. Osteoclasts are very large cells that may be confused with either megakaryocytes or multinucleated histiocytes. On your left, the bony remodeling is a normal feature in a bone marrow core biopsy specimen from children. Osteoclasts reside in lacunar spaces in single black arrow, whereas the osteoblast rim the bony trabeculae in bold blue arrow. Osteoclasts are derived from hematopoietic stem cells, whereas osteoblasts are derived from the mesenchymal stem cells. On your right, the osteoblast rimming is evident adjacent to the bony trabeculae in this bone marrow core biopsy from a teenager. Osteoblasts are bone-forming cells and are normally present in children and adolescents. On your left is a prominent clumping is present on this aspirate smear, reflecting early specimen clotting. This phenomenon may greatly skew differential cell counts and distort cytologic assessment. On your right, skin can sometimes be forced through the trocar needle during the bone marrow core biopsy procedure, as shown in this bone marrow core biopsy. This has become more common due to concerns regarding scarring of the skin from lancing the entry site prior to inserting the trocar needle. On your left is an partial bone marrow aspiration artifact is evident in the center of this bone marrow core biopsy section, showing an area in the biopsy devoid of marrow. Aspiration artifact is caused by performing the biopsy too close to the prior aspiration site. Aspiration artifact can be avoided by performing the biopsy first. On your right, this composite shows a sizable, intact, technically excellent bone marrow core biopsy in bold black arrow, which is adjacent to an inadequate core biopsy showing a crushed bone without your hematopoietic cells. On your left is a gelatinous transformation, which is a change in the marrow secondary to cachexia, can mimic bone marrow aspirate artifact. Red blood cells are infrequent in areas of gelatinous transformation, whereas numerous red blood cells are present with aspiration artifact. On your right, this bony bone marrow core biopsy section is taken from a previous core biopsy site. Note the fibrosis and prominent bone remodeling that reflects the repair process from the previous biopsy. On your left is a bone marrow aspirate from a newborn, which shows a 100% cellularity since few, if any, fat cells are present. This high level of cellularity is physiologic in newborns and in infants. On your right, the bone marrow core biopsy from a 21-month-old infant showing a prominent bone remodeling and mineralization, which is physiologic for patient age. Note that cellularity approaches 100%, which is also physiologic for the age. On your left, hematogones are benign lymphoid precursor cells that show a range and overall cell size. On high magnification, your hematogones show dense nuclear chromatin with inconspicuous nuclei and scant cytoplasm. In a single black arrow. On your right is the lymphoid cells that are especially prominent on bone marrow aspirate smears from young patients. These cells often have morphologic features of hematogones, benign lymphoid precursor cells. These specimens with physiologically increased hematogones can be misdiagnosed as your leukemia. On your left is a bone marrow core biopsy from a 17-year-old boy showing you a prominent bone remodeling and a thick bony trabeculae, which is physiologic for his age. Note that overall cellularity is 75%, normal for the age. On your right is a bone marrow core biopsy from a 52-year-old woman showing you a 50% fat cells and 50% hematopoietic stem cells. Increasing amounts of bone marrow fat cells with decreasing hematopoietic cells is typical with aging. Bone trabeculae is also thinner than in younger patients. Let's talk about the peripheral blood. The peripheral blood is a total blood volume varies by body size. Your blood comprises 7% of your total body weight. The adult blood volume is of 5 liters. Blood consists of predominantly red blood cells and plasma. By centrifugation, your blood can be separated into packed red blood cells, your hematocrit, the plasma and white blood cells, the white blood cells, which we call it the buffy coat. This is your peripheral blood. On your left is by automated cell counting techniques. Your cells pass single file through an aperture and are counted, sized, and interrogated. These two graphs illustrate the size profile. Example, the mean corpuscular volume in curved black arrow of normal red blood cells, and the two most prominent peaks on the white blood cell, the histogram illustrating the lymphocytes in a black single arrow, and the granulocytes in a bold black arrow. On your right is based on size and the cytoplasmic granularity. The differential counts are performed. Your lymphocytes in bold white arrow are small, agranular, whereas your neutrophils are larger and granular. On your left is a peripheral blood smear from a normal adult woman showing you a uniform erythrocytes with a normal central pallor, normal platelets, and a non-activated lymphocyte. There is some variation in platelet size in curved black arrow but are all well granulated. On your right, a normal neutrophil and a large granular lymphocyte are evident and is high magnification on this blood smear from an adult. Large granular lymphocytes are present in low numbers in blood, and cells with this morphology are either natural killer cells or your cytotoxic suppressor T cells. On your left is a normal neutrophil, nuclear segmentation, and a normal granulation of the cytoplasm that are evident in the circulating neutrophil. Neutrophils typically have a 3 to 5 nuclear lobes with a thin strand of your chromatin connecting these lobes. The cytoplasm has a pink tint from secondary granules. On your right, a monocyte is characterized by large size, blue-gray cytoplasm with occasional granules and vacuoles and a somewhat folded nucleus. The nuclear chromatin has a hills and a valleys appearance. On your left is eosinophils that are recognized by the distinctive eosinophilic refractile appearance of the secondary granules as shown in this blood smear. Eosinophils typically have 2 nuclear lobes but sometimes 3 as illustrated here. Basophils on your right are the least numerous white blood cells in the blood. The secondary granules of basophils are dark and coarse. These granules often overlay the nucleus, and these typically show a 3 to 4 nuclear lobes. Note that the adjacent normal red blood cells. On your left is a platelet coupling that is a common artifact in peripheral blood and may interfere with accurate platelet counts. The manual scanning for platelet clumps is recommended on blood smears when thrombocytopenia is detected by automated counting. Platelet satellitism on your right is a artifactual phenomenon in which the platelets adhere to neutrophils. A spuriously low platelet count can result from satellitism. Repeat testing utilizing a different anticoagulant is recommended. On your left is the extracellular amorphous blue globules that's shown here is the cryoglobulin. They can precipitate in peripheral blood, interfering with automated cell counting. On your right, the erythrocyte agglutination is common with patients with a cold agglutinin. Agglutination often results with cooling of specimen during transfer after phlebotomy. Warming the specimen eliminates the agglutination so that the accurate automated cell counts can occur. Note the clumps of erythrocytes in this photograph. On your left is a photo comparing a partially degranulated basophil in lower right with a normal neutrophil in upper left. Note that the basophil granules still overlay the nucleus, and note that the broken neutrophil in bold black arrow is a so-called basket cell. On your right, toxic neutrophils are illustrated that can mimic basophils because of the prominent basophilic granulation that characterize an activated neutrophil. This appearance is due to staining changes in the activated secondary granules. On your left is a blood smear from a term newborn showing a high number of erythrocytes and many reticulocytes. which is physiologic for this age. Leukocytosis with left shift is also physiologic for age, as are nucleated red blood cells in bold blue arrow. The leukocytosis, polychromasia, and your N red blood cells should also decline shortly after birth in healthy babies. On your right is a feature that are physiologic in the newborn period are illustrated in this peripheral blood smear, including prominent polychromasia in bold black arrow, left shift, and leukocytosis. On your left is an immature lymphocytes that are physiologic in infants and young children, even though they are the reminiscent of lymphoblasts. These cells have dispersed chromatin and scant cytoplasm. Hematopoietic parameters are normal and finding useful in the distinction from leukemia. On your right is the peripheral blood smear from a 4-month-old infant, showing a more normal appearing lymphocyte on top in conjunction with a larger lymphocyte that exhibits some nuclear immaturity. The size and nuclear features are physiologic for this age. On your left is a blood smear from a 4-month-old boy showing a predominance of lymphoid cells, an absolute lymphocyte count of 10.8 times 10 to the 9th per liter, which is physiologic for age. On your right, it is important to scan the feather edge of a smear during a manual morphologic review to detect cells and even microfilaria worms that have been dragged to this portion of the blood smear. Larger cells such as your immunoblasts in bold black arrow are often pulled to the feather edge in the preparation of blood smears as well. Next is your pediatric thymus. Your thymus is located in the midline anterosuperior mediastinum. This is composed of 2 lobes. In each lobe is composed of lobules. The size and weight may vary with age from person to person. Despite involution and atrophy, the overall size and shape of the thymus remains the same, and its main function is responsible for T lymphocyte development. So let's talk about the pediatric thymus. On your left is markedly compartmentalized with lobules of lymphoepithelial tissue separated by wispy fibrous interstitium and white single arrow. The Hassel corpuscles can often be seen at low magnification and bold white arrow. On your right is within each lobule are 2 compartments, the dark outer cortex, the single white arrow, and a pale inner medulla in bold white arrow. In this disparity in color is due to the presence of significantly more lymphocytes in the cortex than in the medulla. On your left is there is usually a connective tissue at the periphery of the thymus in curved blue arrow, and this capsule varies in size from a thin and wispy to thick and fibrous. It is contiguous with the fibrous interstitium between the thymic lobules. On your right, the cortex in white arrow is composed predominantly of immature T lymphocytes and a few epithelial cells, giving it a darker appearance than the adjacent medulla in white single arrow. The pink squamoid Hassel corpuscles are easily visible against the background of lymphocytes in curved white arrow. The immature T lymphocytes on your left is found in the thymic cortex that have very little cytoplasm and are closely packed. The larger thymic epithelial cells are interspersed between the lymphocytes and can be identified by their more abundant cytoplasm in white curved arrow. On your right is compared to the cortex, the thymic medulla contains a much larger population of pink thymic epithelial cells in a bold single arrow and a small proportion of dark T lymphocytes in bold blue arrows. The Hassel corpuscles are composed of keratinized epithelial cells on your left and arranged in concentrically oriented nests in blue bold arrow, which contain keratin debris in curved blue arrow, and these unique structures are easily seen in the medulla even at low magnification and are very useful in identifying the thymic tissue. On your right is a pancytokeratin immunostain highlighting the thymic epithelial cells, while the thymic lymphocytes or the thymocytes are negative. Note also the positivity of the keratinized Hassel corpuscle in curved black arrow. On your left is a thymic T lymphocytes that can be highlighted by a variety of immunostains, including the CD3 as shown here. Note the epithelial cells in the Hassel corpuscles in blue curved arrow are negative. On your right, after puberty, the thymus begins the process of physiologic involution or atrophy, during which the thymic lymphoepithelial tissue in single white arrow are gradually replaced by mature fat in bold black arrow. Calcification in a white curved arrow of the Hassel corpuscles on your left is often seen in least focally in thymic tissue undergoing involution, Other alterations to these structures include cystic change and inflammatory infiltrates. On your right, in some areas of atrophic thymic tissue, the epithelial cells in a blue single arrow appear to form a layer around the periphery of the thymocyte aggregates and can be distinguished by their more abundant pale eosinophilic cytoplasms. On your left is a process of involution. The thymic atrophy can result in small nests or aggregates of atrophied epithelial cells in a white bold arrow. And these are reminiscent of a neuroendocrine proliferation such as your carcinoid tumor. On your right, in older age group, the thymic lymphocyte parenchyma may show marked atrophy and fatty replacements. However, the epithelial elements in curved blue arrow will remain. On your left is a reactive germinal center formation in a white curved arrow that can be seen on otherwise normal thymus glands, particularly in a pediatric age group. However, they are also characteristically prominent in immune-mediated conditions such as your myasthenia gravis. On your right, in the pediatric population, the mediastinum contains a prominent component of brown fat in curved black arrow, and it's not unusual to see nests or sheets of these multivacuolated, often pink granular cells adjacent to your thymic lobules in single black arrow. Left is an artifactual cracking or clefts that may be present in some thymic specimens as depicted here and are related to tissue processing. On your right, the intraparenchymal blood may be identified in some thymus specimens secondary to surgical manipulation. It can also be seen in post-mortem specimens, and in this image, both thymic epithelial cells in curved blue arrow and lymphocytes in a black single arrow are also visible. And lastly, in some cases, on your left, the thymic lymphocytes may appear to clump together in small aggregates in blue curved arrow. On your right is cauterization during surgery is a common cause of histologic artifact, especially um, elongation or spindling of both thymic epithelial cells and lymphocytes. This morphology can lead to a mistaken impression of a neoplasm, such as your thymoma and sarcoma. Crush artifact may also occur, not shown here, resembling a morphology often seen as small cell carcinoma. And that's the end of your hematopoietic and immune systems. Second part. Up next in your medical histology laboratory is the circulatory system. Before we end, don't forget to like and subscribe this YouTube channel, and I hope you've learned something from this presentation series. Have a nice day, everyone. Thank you.